Hello, everyone. Good to meet you. Good to meet you virtually. I have a lot of fondness for Australia because all my family lived in Sydney. My brothers Don and Peter, and my sister Nancy and their families are in Sydney. I visit them once in a while. So good to be with you virtually. Let me proceed and give you my presentation about how we can actually prevent how we can prevent the deterioration of schizophrenia that we usually see by preventing the second episode. This is something based on literature and studies and also my own personal experience, because like Jose said in the previous presentation, I absolutely advocate for using long-acting injectables at the first episode, not after multiple episodes, and I'll tell you why right now. First, just to orient you, Cincinnati is here in the southern part of Ohio, and the University of Cincinnati is the third oldest medical school in the United States. Out of 150 medical schools, it's only the only two older ones are Harvard and Pennsylvania. And next, just as usual, I start by showing you the symptom clusters of schizophrenia, the domains, because what we're talking about is the positive symptoms, which is really the malignant part of schizophrenia. The negative and cognitive deficits have no treatment yet. We have treatments for the mood, of course, but those two, negative and cognitive, precede the onset of psychosis, and it's the psychotic relapses that, in my opinion, destroy the patient's brain and the patient's outcome. So basically, schizophrenia is widely accepted as a neurodevelopmental disorder, a syndrome actually, with several hundred subtypes. Schizophrenia has maybe a very uniform phenotype, but it has hundreds of biotypes based on genetic and non-genetic data that have emerged over the last 10, 15 years. But this neurodevelopmental disorder becomes neurodegenerative because of progressive brain atrophy at the onset of psychosis. So here's an example of a patient we saw over about 10 years. First episode, this MRI at the bottom is the first episode. You can see the ventricles of this patient, coronal section are already dilated. They should be more like a slit. 3 relapses later, they have quadrupled in size. And then about 10 years later, with multiple relapses, this patient didn't always come to our hospital. He went to other hospitals as well. But you can see his brain now is like early Alzheimer. So this is what happens to patients with schizophrenia. Numerous studies have shown this. And by the way, we did not know this until 21 years ago. Okay, this is one of the earliest studies. And you can see the after one episode, first episode psychosis, you lose 1% of the brain, which is 12 cc's. The brain is usually 1200 cc's. And most of it comes from the cerebral gray volume, which is 3% decline, and a lot of thinning, cortical thinning happens. And then the ventricles dilate about 6-7%. Every relapse usually destroys about the same amount of tissue. So you can imagine how much deficits in the brain. Brain is ravaged with multiple episodes. It's our duty as physicians never to let the patient have another psychotic episode. And yet, like Jose said, and I keep lamenting this fact every day, 99% of all clinicians in this country discharge the patient on pills. We always start with pills in the hospital, of course, but at the time of discharge, we should switch them to the injectable. But what they do is, just because the pills worked at the hospital, they think they're going to work outside. They don't, because the pills do not enter the patient's mouth on a consistent basis like they do in the hospital with the supervision of the nurses. What's the cause of the destruction? Again, in the last 18 years or so, we found huge amount of free radicals are released from the microglia in the brain, which, by the way, get activated at the time of psychosis, and also neuroinflammation. The patient's brain is being burned and destroyed, chewed up by free radicals. And we know this for a fact. I mean, we measure biomarkers of inflammation like cytokines, interleukins, TNF alpha, interferon gamma, CRP, cortisol, etc. They're all elevated, extremely high in CSF and blood during psychosis, and they go back to normal after emerging from the psychosis. So I wrote an article about the 7 tragic consequences of psychotic relapses, which is absolutely tragic. First, brain tissue loss. 12 cc's every area. Even 1 cc has millions of cells and billions of synapses. We're talking about a huge destruction of the brain. with repetitive episodes. Treatment resistance emerges with every episode. About 15% of patients become treatment resistant. This has been shown with follow-up studies. And that means you need higher and higher doses compared to the first episode, which responds beautifully to low doses. Then you have the arrest and incarceration. I don't know about Australia, but here half the patients with schizophrenia end up in prisons and jails. There's no more state hospitals to treat them with dignity in a medical setting. They get shipped to jail and they get sentenced to prison, and they end up with criminals and rapists side by side, and they become felons. It is such a tragic outcome of relapse. The only reason they get arrested is because they become psychotic on the streets. And then the suicide rate is unbelievably high. Many clinicians are not aware of the studies, but when we talk about 100 times, that's 10,000% higher suicide rate in the first 2 years or 3 years of schizophrenia compared to same population, young adults, same age in the general population. This is very, very often attributed to lack of treatment, because some studies looked at the blood level of antipsychotic in the corpses of patients who committed suicide, and they found hardly any antipsychotic in their body. And then disability, of course, they lose everything. No more college education, no more work, no social circle, nothing. Become homeless, and basically they're very costly to society in many ways, both financial and social. So that's why avoiding any additional relapses is, in my strong opinion, the best paradigm. And I've treated thousands of patients with schizophrenia over the years, and I've seen it with my own eyes that if we switch to injectables at the time of discharge from the hospital, at the first episode, many of those patients, most of them in fact, go back to school, go back to work, resume their life, they go to their baseline. We don't make stars out of them, they just go back to their baseline, whatever they were doing. And the number one cause for relapse, as you well know, is non-adherence. And non-adherence is so ubiquitous, and I consider it a symptom of schizophrenia, inability to take medications. And there are many reasons for that. Of course, the most obvious one is anosognosia. Patients absolutely deny that there's anything wrong with them. They have no insight, and so they don't believe they need medication. They have also impairment of memory. Memory is horrible in schizophrenia, and they forget everything, even if they wanted to do it. The negative symptoms are also a killer for adherence because of a lack of motivation and avolition, inability to initiate an action. And then the side effects to them, it's evidence that they're being poisoned, so they ditch it. And then finally, alcohol and substance use is so common. I do urine screens on all my patients, the patients who refer to me, and about 70% of them have at least one drug in their body. And do you really think somebody who is drunk or stoned is going to take their prescription medication? Of course not. You add up all of these things and you realize that patients self-destruct. And we need to protect them from that by taking the initiative. I know it's compassionate paternalism, as I call it. We need to basically convince them to get on medication, on the injectable, and save their life. Otherwise, they're going to be doomed. So there's a science and logic actually to using the second generation very early. Let me show you. The very first study was done by Dr. Emsley, Robin Emsley, a good friend. He was chief of psychiatry in South Africa. He did the first study in 2006, a 2-year study using the first long-acting second generation. He didn't want to use any of the older ones. I'll tell you why later. So injectable risperidone, and he recruited 50 patients from the community. They all signed up for a 2-year study, and he gave them risperidone injectable between 25 to 50 milligrams every 2 weeks for 2 years. And then he published his data in 2008. What did he report? 2/3 of the patient, complete remission. They didn't have hardly no relapses for 2 years. And they basically went back to work, and they had their insight came back, and they had social and occupational function, and they also did very well with low doses and very few side effects, which is an ideal, scenario. What happened afterwards? Well, he sent them back to the referring psychiatrist, who automatically put them back on pills, because that's how they practice. They don't see the benefit because of the old hard habits that are ossified in their practice. They switch them to oral antipsychotics, and guess what happened? I talked to Robin about this. 97% of the patients rebound, almost 100%. After getting their life back for 2 years, they lost it again. And not only that, here's another thing that emerged. those clinicians said, okay, we'll put them back on the injectable that worked so well. Well, they did, but 16% never responded again. Of those who were doing great for 2 years, 16%, almost 1 in 7, 1 in 8, never responded again. That's treatment resistance that happens under our noses, and many clinicians are not aware of it. They attribute it to schizophrenia. No, it's attributed to allowing the patient to relapse again, which is the malignant part of schizophrenia. So here's another study from UCLA. Sabatnik and colleagues, actually, Rutterland is the main senior author. They got 100 patients with first episode, treated them with oral risperidone, again, in the hospital. And then at the time of discharge, half of them were put on injectable, half of them were kept on the oral risperidone, half were switched to injectable. And they followed them up for a whole year to see the difference in relapse rate. Well, it was enormous. This is what they reported in a major journal, JAMA Psychiatry. 650% lower relapses, or if you look at it the other way, higher relapses in the oral group compared to the injectable group. It's incredible, 33% versus 5%. This is what's happening all the time in the world, because very, very few clinicians are finally getting it and realizing we can do something about this illness, instead of doing the same thing again and again and again and giving them pills they don't take, and then maybe go to clozapine after multiple episodes, which Jose told you, and I completely agree. The longer you wait for clozapine, the less it works. Use it early. Again, that's another vastly underutilized pharmacotherapeutic agent. LAIs, long-acting, and clozapine in the United States, it's dismally low for both of them. And it really makes me angry, because we can save a lot of young lives. So this is what I think the typical patients, after a prodromal period, they relapse, they get first episode, and look at the V-shaped recovery. Only in the first episode, you get a quick response, V-shaped recovery with low doses. Well, if they only stay on it, they would stay okay, as I'll show you later, but they don't. They stop taking the medicine. Even partial non-adherence is not enough. A study published in an American journal a few years ago showed that a drop of 25% was enough to cause a relapse. In other words, missing one pill every 4 days. So even partial non-adherence can doom the patient. So now they get the second episode, no more V-shaped recovery, now latency, now treatment resistance started, a slower response, not as gratifying. But if they stay on it, it may take longer, but they'll eventually get there. Again, hardly anybody ensures that they do by giving them LAIs at the second episode. And so they get a third episode, and a fourth, and a fifth. And you see the decline in the response. And below each episode, if you do an MRI, which very few people do anyway, except in research, you see the ventricles dilating, which means cortical tissue loss has taken place. And the expansion of the ventricles is a proxy for brain atrophy. This is the model I'm suggesting and strongly recommending for my own trainees, that instead of waiting after multiple episodes to give them an injection after 10 years or 10 episodes, whatever, do it right after emerging from the first episode and watch them go back to their baseline, which is so gratifying. I see it in my own patient. It is unbelievably gratifying, for the vast majority. Yeah, there are a few who relapse, but you're salvaging 80-90%. That is wonderful outcome in medicine. So that's why I tell all my trainees, we have to behave like cardiologists. Psychiatrists must behave like cardiologists. And when they say, what does that mean? I remind them that when a patient comes in with the first heart attack, it's actually myocardial infarction. They lose a chunk of myocardium. Heart muscle is dead forever, gone. And the heart is much weaker. So what do every cardiologist do? Every cardiologist makes it an absolute goal, never, ever, ever let the patient have a second myocardial infarction, because then the heart will lose more myocardium, may even die outright, or become so weaker, and heart failure is very hard to treat with in general, especially with the transplant. So every cardiologist adopts multiple interventions to protect the patient. Example, they reduce all the risk factors. First and foremost, stop smoking immediately, risk factor. Second, is change your diet from high fat, high calorie to low fat, low calorie, and Mediterranean diet. Okay, lose some weight. And number three, start exercising. Most of them are couch potatoes. They never move in the 50s and 60s when they get their heart attack. So they start strengthening their heart and lung fitness. And then they give them multiple medications to reduce risk factor, hypoglycemic agents to reduce the glucose. antihypertensive drugs to reduce the blood pressure, and statins to reduce the lipids. All of this in order to protect them from a second heart attack. Friends, I like to call psychosis a brain attack because that's exactly what it is. Maybe if we change the term psychosis to brain attack, maybe the public will become more compassionate to our patients. They realize it's like a heart attack and it's less stigmatizing. So it's exactly the same thing. Brain attacks, patients lose hundreds of millions of brain cells every time they get a psychotic episode. And therefore, we psychiatrists must do everything in our power never to let them have a second episode. How do we do that? In my opinion, the only way I know how is to guarantee adherence by injecting them with a second generation antipsychotic. I emphasize second generation, please. I'll tell you why in a minute. First generations work, but they are very toxic, turned out. And so preventing the second episode is something that actually have been looked at for a while. And we know it is a very important therapeutic target. And recently in Lancet Psychiatry, an article from Finland with Tihonen, who's a well-known researcher, they looked at thousands of patients and found really that the disability actually starts after the second episode, not after the first episode. You can bounce back from the first episode, and yet I bet you most clinicians never read this article. So I wrote another article which is simple: 3 steps to bend the curve of schizophrenia from a deteriorating downhill course to a steady course with no deterioration. How do you do that? Well, first, minimize the duration of untreated psychosis, which many times patients wait for months before they get the first hospitalization, mainly because parents and society is so stigmatized. They don't want to bring them to the hospital. They put up with bizarre behavior and hallucination while sitting, living in the basement of their house. This is horrendous to the brain. The earlier the treatment, the better. That's number 1. Number 2, injectable, second generation injectable at the discharge from the first hospitalization. And number 3, psychosocial therapies. We have so many tools, supportive therapy, social skill training, vocational rehabilitation, cognitive remediation. All of those things should be given to the patient as they come in every month for their injection, or even if their injection is every 3 months or 6 months, now they're available. Still, we see them monthly to provide them with the psychosocial interventions, which is synergistic with the pharmacotherapy. But the foundation is protecting the brain from the toxicity from the psychotic episode. So here's why I only advocate for second generation. I haven't used the older drugs, even though I used them in my career. They work. Definitely they work. Haldol and other drugs. But we found in the last 20 years, 32 studies, actually it's now 32, but 31 studies in the slide have shown, they're all published in neuroscience journals, which clinicians don't read. And so that's why I get fed up because there's so much evidence, 15 molecular mechanisms of cell death. So I summarized them, I reviewed them with one of my research fellows and put them in a clinical journal, multiple neurotoxic effects of Haldol and the other first generation. And here are the 15 mechanisms. Every bullet here was reported as occurring when you use a first generation. Each of them kills brain cells. Every single one of them is destructive to neurons. So that's why patients who receive Haldol, they respond very well to psychosis, from the psychosis point of view. But if you continue to do imaging over time, and this has been done, I'll show you the paper in a second, the brain continues to shrink. Brain atrophy continues to happen with treatment, even if Haldol is working.
Professor,
and then
Professor, we've only got 1 more minute.
I'm rushing. Okay. On the other hand, there are 24 studies showing that the second generation are actually neuroprotective. Here are some of the aspects of neuroprotection: anti-inflammatory, increasing NGF, the neurotropic factors, even reducing strokes in animals. I mean, it's of course all indicative of neuroprotection. And here's the study I told you about: 18 study meta-analysis where they compared first and second generation. Biological Psychiatry is a journal, and they found that the first generation patients over 10 years with repetitive MRI scans continue to lose brain tissue. The second generation do not. They continue to have the same volume. And then mortality is a huge problem in schizophrenia. Nobody has looked at the effect of medication until Tihonen and his group, again, in Sweden, did a 7-year study where they kept the patients on the same medication for 7 years. And they counted the number of deaths in each group. First generation, second generation, oral, injectable, doesn't matter. And what did they find? Absolutely, the lowest mortality was with the second generation long-acting injectable, and the others, they higher and higher and higher, even up to 800% higher the mortality with the first generation long-acting injectable flufenazine. So we can reduce mortality and have neuroprotection and relapse prevention. That's the triple advantage I wrote about. This is it, my last slide. With 100% guaranteed adherence, most patients will not only stop relapsing, but they can achieve remission and get baseline return to their baseline. I strongly suggest that you use this approach to schizophrenia. Thank you very much for your attention.